Hello friends, this is Dr. Saminajo from Ophthalmology Clinic, Hyderabad, Pakistan. Today I will show you a case of small pupil Phacoemulsification followed by intraocular lens implantation. This is a patient whom the trabeculectomy operation was performed 3 months back, and now the secondary Phaco IOL implantation is being done today. And you can see that there are posterior synechiae and the pupil is irregular. And now I have injected cystotome outside the border of the pupil is stretched on the lateral sides to break the posterior synechiae by means of needle cystotome, saving the anterior capsule. The anterior capsule should remain intact and only the pupil is widened so that the posterior synechiae, posterior adhesions should be broken down all around. At 360 degrees the pupil is widened, stretched towards the outer margin so that the synechiae should break and the pupil should become a bit wider. And now you can see that the pupil is in a bit dilated position. Still it's small pupil, but better than before. And now I will do the anterior capsulotomy. Rather, anterior capsular axis. The pupil is acting like a guard, and the anterior capsule is being separated from the rest underneath the pupillary margin. In this patient, at this time, the pupil is not more than 3.3 to 3.5 millimeters in diameter. At the 12 o'clock position, cane opening technique is applied to complete the capsular axis. As there is a manipulation inside, there is a release of the posterior in situ from the artery stroma, and the pupil is again becoming smaller and smaller in size. And now I will inject OVD dispersive and form the intraocular pressure enough to complete the full thickness corneal incision at the outer border of the trabeculectomy filtration blade. On the other side, at 8 o'clock position almost, I will do the side port formation. This is the first side port which is formed at 8 o'clock position, and the second side port at almost 3 o'clock position. I will inject more viscoelastic solution to deepen the anterior chamber to lubricate the inside exactly behind the iris, and I am trying to do the visco dissection. As the pupil is small and the lens is almost 3 plus in density, and there are a lot of adhesions still in between the cataract and the posterior iris. So I have completed the visco dissection, and again I will inject OVD dispersive to provide more lubrication. Particularly in those cases when we come across a small pupil, it is very important to complete the hydrodissection and delineation along with visco dissection, so that within a small pupil, when we start phacoemulsification, the nucleus should easily prolapse out from the bag. And now you can see that pupil is smaller and smaller due to the release of the prostaglandin C2 from the iris stroma, and I will make a small groove exactly in the middle, and then under a high vacuum I will pull the nucleus out. As you see that the equator is very clear, equator is out, it is out of the pupillary margin, and the nucleus has left the capsular bag, and now I am very comfortable in a better position to break the nucleus into small fragments. Throughout the procedure, I should keep the phaco hand tip exactly in the middle of the pupillary zone in order to save the pupillary rim, any trauma to the pupillary rim. Very slowly and gently I keep on fragmenting the nucleus, and under high vacuum of 550 millimeters of mercury, aspiration is also in the process. I will never try to move the phaco tip at the outside the middle of the pupil in the eccentric or mid-eccentric area in order to avoid the traumatic pupillary capture. A lot of patience is required. Not to hurry, don't rush. Within a couple of minutes, almost the whole nucleus is removed out, and at the moment only the epinucleus and a cortical matter is remaining inside. I also have to take care of the filtration bleb, a working filtration bleb, not to injure or traumatize it. Viscoelastic solution is injected in the bag and behind the iris as well. This is the time when I have to wait for a couple of minutes, maybe 1 to 2 minutes, so that the epinucleus and the cortical matter should get liquefied by itself in presence of viscoelastic solution. And now with the help of nucleus manipulator, I have tried to dislodge the epinucleus, loosen it so that it should come out comfortably without inducing any trauma to the posterior capsule. And now two-way irrigation and aspiration synechiae is used from the inner side port. The side port at 3 o'clock is being used, and very slowly and gently the epinucleus is being pushed from periphery and it is moved in the middle of the pupil, in the center, from all the 4 quadrants. At the moment I will not try to remove it, but I am trying to dislodge it. I am trying to dislodge the epinucleus. I will not try to aspirate it at the moment because there are a lot of adhesions in between the epinucleus and the posterior stroma, and if I apply force on that, there can be a posterior capsular rent. So in order to save the posterior capsule, I will first dislodge the epinucleus by means of simple cannula, bring it into the middle of the pupil, and then in presence of a Ringer's solution flow and the viscoelastic solution, I will do the irrigation and aspiration very slowly and gently without applying any negative force. I will try to aspirate. Now the cortical matter, almost the whole epinucleus has been removed, aspirated, and now I will try to remove the cortical matter by means of Simcoe irrigation and aspiration. And I will try all the time, I will try to keep the Simcoe cannula tip superficially at the interpupillary zone. The Simcoe cannula is not deeper to avoid posterior capsular rent. This is for the 3rd or 4th time I am injecting the viscoelastic solution from behind the cortical matter. Just to bring about maximum lubrication. This is all being done to dislodge the epinucleus and cortical matter, and very slowly and gradually, in presence of a small pupil, the cortical matter along with a bit of the epinucleus is being aspirated. I will again repeat that please don't rush at the moment. Be patient. Wait for the moment to come when the cortical matter will dramatically get dislodged and aspirated within no time. As soon as the time passes out, the cortical matter is getting liquefied. Adhesions are being broken and the nucleus and the cortical matter is out. Now we only have a very good posterior capsule intact, complete bag. In presence of OVD dispersive, the hydrophobic intraocular lens is being implanted exactly into the bag. This is a yellow aspheric hydrophobic intraocular lens, which is now being implanted exactly into the bag. Still the pupil is smaller in size, but we are so lucky that the things are done very comfortably without putting the patient into further trouble. Lens dialing is done in the bag and the task is complete. My dear friends, this is another case of a small pupil where we are doing the Phacoemulsification in a small pupil, again pulling the nucleus out of the bag and removing it by means of aspiration through the phaco tip. This has only happened when we have thoroughly done the hydrodissection, viscodissection and delineation in a small pupil. A vigorous, complete hydrodissection and viscodissection is eminent in small pupils, so that the nucleus should leave the bag without applying any extra efforts. Thank you very much, my dear friends. If you like my video, I will request you all to please subscribe my channel and like it. Thank you very much. Take care.